Welcome to another Speed Pharmacology video. Today we'll explore the pharmacology of drugs used in the treatment of anemia. To understand how these medications work, let's first walk through the physiology behind red blood cell production and iron metabolism, since these processes form the foundation for nearly every therapeutic approach. So red blood cells, or erythrocytes, are produced in the bone marrow through a process called erythropoiesis. This begins with pluripotent stem cells, which give rise to erythroid progenitors that mature under the influence of erythropoietin, or EPO, a hormone made primarily by the kidneys. When oxygen delivery to renal tissue drops, specialized peritubular cells sense the hypoxia and secrete more EPO. This hormone travels through the bloodstream and binds to receptors on early red cell precursors in the marrow, activating intracellular pathways that prevent apoptosis and stimulate proliferation. As the cells differentiate, they accumulate hemoglobin, expel their nuclei, and eventually become reticulocytes, which enter the circulation and mature into red blood cells. A typical red cell lives about 120 days before being removed by macrophages in the spleen and liver. Healthy erythropoiesis also depends on a steady supply of iron, vitamin B12, and folate, along with adequate bone marrow function and supporting cytokines. Iron metabolism is equally crucial. Most iron absorption occurs in the duodenum and upper jejunum. Dietary non-heme iron is reduced from the ferric to the ferrous form by duodenal cytochrome B, then transported into enterocytes by DMT1. Inside the cell, iron may be stored as ferritin or exported to plasma through ferroportin. Once in the bloodstream, it binds to transferrin, the carrier protein that delivers iron to tissues, particularly the marrow for hemoglobin synthesis. The key regulator of systemic iron balance is hepcidin, a peptide hormone produced by the liver. When body iron is abundant or inflammation is present, hepcidin levels rise, causing ferroportin degradation and reducing iron export into plasma. Conversely, iron deficiency or hypoxia suppresses hepcidin, promoting absorption and mobilization from stores. A finely tuned relationship among iron supply, hepcidin, and erythropoietic demand ensures adequate hemoglobin production without toxic overload. Anemia arises when something disrupts this equilibrium. The causes are broad: iron deficiency from blood loss or malabsorption, vitamin B12 or folate deficiency leading to megaloblastic changes, impaired EPO production as seen in chronic kidney disease, marrow suppression from toxins or chemotherapy, chronic inflammation that traps iron and blunts the marrow's response, or excessive destruction of red cells in hemolytic states. Understanding the underlying mechanism guides drug therapy, which aims either to replace missing substrates, stimulate red cell production, or counteract pathological destruction. Now let's begin with iron therapy, the cornerstone for iron deficiency anemia. Oral preparations such as ferrous sulfate, ferrous gluconate, and ferrous fumarate all supply iron 2+, which is absorbed in the duodenum via DMT1. From a pharmaceutical perspective, these salts mainly differ in their elemental iron content per dose and their tendency to cause GI side effects, not in their basic mechanism of action. Absorption is greatest in an acidic, empty stomach environment and is enhanced by vitamin C, but irritation of the gut mucosa explains common adverse effects such as nausea, constipation, abdominal discomfort, and dark stools. Now, when rapid iron repletion is required or when intestinal absorption is reduced, as in inflammatory bowel disease, post-gastric bypass, or with large ongoing blood losses, parenteral iron is preferred. Intravenous products such as iron sucrose, ferric gluconate, ferric carboxymaltose, ferromoxetol, and iron dextran are iron carbohydrate complexes that differ in how tightly they bind iron, how quickly they release it, and how large a single dose can be safely infused. These complexes are taken up by macrophages in the reticuloendothelial system, which then slowly hand iron off to transferrin, limiting free, reactive iron in plasma. They are generally safe, although rapid iron release or immune reactions to the complex can cause transient hypotension, flushing, or rarely, severe hypersensitivity reactions, which were more frequent with older high molecular weight iron dextran formulations. Next, let's discuss vitamin B12, also known as cobalamin, and vitamin B9, also known as folate. B12 and folate work together as a linked system for DNA synthesis, and in the case of B12, for nerve health. Vitamin B12 acts like a methyl carrier in the methionine synthase reaction. It takes a methyl group from a methylated form of folate and passes it to homocysteine to form methionine. This step frees folate back into its active pool so it can be reused to make DNA bases. If B12 is lacking, folate becomes trapped in its methylated form, usable folate levels drop, and bone marrow precursors can't divide properly, leading to large immature red blood cells and megaloblastic anemia. Because B12 is also involved in reactions that help maintain myelin, deficiency can cause both anemia and neurologic problems, such as numbness and gait disturbance. Now, folate physiology is best understood from the standpoint of the drug we actually give: folic acid. After absorption, folic acid is converted inside the body into several active folate forms. One of these is methylfolate, the specific form that transfers methyl group to vitamin B12 so the folate cycle can continue. These active folate forms supply the 1 carbon units needed to build purines and thymidine for DNA synthesis. When synthetic folic acid or natural dietary folate intake or conversion is inadequate, rapidly dividing bone marrow cells cannot make DNA efficiently, leading to the same megaloblastic appearance seen in B12 deficiency, but without the classic neurologic damage. This mechanism also explains why giving folic acid alone can correct the anemia in a patient who actually has B12 deficiency, while the underlying B12-dependent nerve injury continues to worsen if B12 is not replaced. For patients whose anemia comes from not making enough erythropoietin, such as chronic kidney disease or chemotherapy-related marrow suppression, pharmacologic stimulation of erythropoiesis can be life-changing. Recombinant erythropoiesis-stimulating agents, or ESAs, such as epoetin alfa, darbepoetin alfa, and methoxypolyethylene glycol epoetin beta, are lab-made versions of EPO. They bind to erythropoietin receptors on erythroid progenitor cells in the bone marrow and trigger JAK-STAT signaling, which helps these cells survive and divide. As a result, red blood cell production increases, hemoglobin rises, and the need for transfusions falls. However, if the hemoglobin is pushed too high or the dose is too aggressive, the blood becomes more viscous and the risk of hypertension, thrombosis, and stroke goes up, so we aim for a moderate hemoglobin target rather than full normalization. Adequate iron stores are also essential because as the marrow ramps up production, it quickly uses up available iron. And without enough iron, the response to ESAs will be poor. Building on the idea of boosting erythropoiesis, a newer strategy for anemia of chronic kidney disease works one step upstream by increasing the body's own EPO production and improving iron use. Instead of giving EPO from the outside, these drugs target the hypoxia-inducible factor system, also called HIF, which allows cells to sense low oxygen and adjust gene expression. Under normal oxygen conditions, enzymes known as prolyl hydroxylases add hydroxyl groups to the HIF alpha subunit and tag it for degradation, so very little HIF remains active. When oxygen is low, or when we block prolyl hydroxylase, HIF alpha is no longer destroyed, so it accumulates, moves into the nucleus, and turns on genes that increase erythropoietin synthesis in the kidney and increase iron-handling proteins. Oral HIF prolyl hydroxylase inhibitors, such as roxadustat and daprodustat, stabilize HIF alpha, causing endogenous EPO levels to rise and the liver to make less hepcidin, which releases iron from stores and improves absorption. The net effect is more red blood cell production with better iron availability using the body's own regulatory pathway instead of recombinant hormone. Because these are oral agents, they can be a convenient alternative to injections for some patients, but like ESAs, they may increase the risk of hypertension, thrombosis, and possible electrolyte problems such as hyperkalemia, so their long-term safety is still being studied. Beyond iron replacement, vitamins, ESAs, and HIF stabilizers, some anemias require more specialized approaches that target specific blocks in red blood cell production. In hereditary sideroblastic anemia, the defect is in the first step of heme synthesis in the mitochondria, where the enzyme ALA synthase uses vitamin B6 as a cofactor. High-dose pyridoxine can boost the residual activity of ALA synthase in B6 responsive cases, so more heme is made and red blood cell production improves. In transfusion-dependent beta thalassemia and certain myelodysplastic syndromes, the main problem is ineffective erythropoiesis at the late stages of maturation, with many erythroid precursors dying before they become mature red cells. Luspatercept, a fusion protein, acts as a ligand trap for selected transforming growth factor beta, or TGF-beta, superfamily ligands, such as activins and GDFs, which normally signal through SMAD pathways to slow late erythroid differentiation. By binding these ligands in the circulation and removing this inhibitory signal, luspatercept lets late erythroid precursors in the bone marrow mature more effectively, raising hemoglobin levels and reducing transfusion needs, even though the underlying genetic defect remains. Even with these targeted therapies, not all anemias are production problems. In hemolytic anemias, red blood cells are destroyed faster than the bone marrow can replace them, so the pharmacologic goal is to remove the trigger and slow red cell clearance, not simply to stimulate erythropoiesis. If hemolysis is drug-induced, stop the offending agent, and if infection is driving it, treat the infection. In autoimmune hemolytic anemia, antibodies bind to red cells and mark them for macrophage-mediated removal. Corticosteroids reduce hemolysis by dampening immune activation and decreasing this antibody-driven clearance, and if hemolysis persists, rituximab targets CD20 on B cells to reduce autoantibody production upstream. Because turnover is high and reticulocyte production increases, folate supplementation is often used to support nucleotide synthesis during accelerated erythropoiesis. When hemolysis is severe or symptomatic, packed red blood cell transfusions rapidly restore oxygen-carrying capacity, but repeated transfusions add iron that the body cannot actively excrete. For chronic transfusion exposure, iron chelation may be needed, with deferoxamine as a parenteral chelator and deferocyrox as an oral option, both binding excess iron for elimination to prevent iron overload complications. As we bring everything together, treating anemia starts with identifying the mechanism and choosing the therapy that fixes that specific defect. Iron restores the raw material for hemoglobin. Vitamin B12 and folate restore DNA synthesis for normal red cell maturation. When the signal is low, ESAs and HIF Stabilizers increase erythropoiesis by boosting EPO activity and improving iron availability. For select disorders, pyridoxine supports heme synthesis in B6 responsive sideroblastic anemia, and luspatercept lifts the brake on late-stage red cell maturation. When anemia is driven by destruction or marrow failure, the focus shifts to stopping the cause, using immunosuppression when appropriate, and supporting with transfusions with iron monitoring and chelation if transfusions become chronic. And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.